Over 1.65 million. That is the number of cases logged just last year for a single infection here in the United States. I mean, 1.65 million.
Yeah, it's a completely staggering statistic, honestly.
It really is. But here's the paradox that completely breaks how we normally think about disease, and it's basically the reason we are doing this deep dive for you today. Almost none of those 1.65 million people actually felt sick.
Right. When you dive into the federal surveillance data, you are looking at the single most commonly reported notifiable infection in the country.
Yeah.
And yet the vast majority of the people carrying it are just going about their day. You know, they're going to work, they're going to the gym, completely unaware that an organism has literally taken up residence inside their cells.
Which means that the 1.65 million, that's just the number of people we actually managed to find, right?
Exactly. The true number of infections out there is undoubtedly vastly higher. We're just seeing the tip of the iceberg.
So we are talking about chlamydia today. And our mission for you on this deep dive is to pull apart this massive silent epidemic. We've got a huge stack of sources today.
Yeah, a really fascinating dossier. We're pulling from CDC surveillance data, U.S. Preventive Services Task Force guidelines, and some really incredible historical public health records.
Right. And we want to use these sources to understand not just the disease itself, but the, incredible invisible machinery our society had to invent just to fight it.
Because you really cannot fight a silent disease the way you fight a loud one. I mean, historically, when a pathogen causes a fever or a rash or severe pain, public health responds with these sweeping, highly visible treatment campaigns.
Like the disease announces itself and the doctors react.
Precisely. But chlamydia is defined entirely by what you cannot see.
Right.
And because of that, the modern federal public health response had to completely shift away from those loud campaigns. Instead, they had to build this quiet, structural machine of mass screening.
A machine designed to hunt in the dark. I love how the sources frame that.
It's the only way to catch it.
So if we're going to understand why this massive public health machine was built and, why it's so incredibly vulnerable today, we have to start at the cellular level.
We do.
We really have to understand the terrifying biological reality of an infection that asks absolutely nothing of its host.
It really is a masterclass in biological stealth. The bacterium responsible for this is called Chlamydia trachomatis.
Okay.
And to understand its silence, you really have to look at how it operates inside the human body. This is what we call an obligate intracellular parasite.
Meaning it has to live inside our cells to survive, right? Like it can't just hang out in the bloodstream or the tissue.
Exactly. It needs the host cell to live.
Bah.
And it has a fascinating biphasic life cycle to achieve this. Basically, it exists in two completely different forms.
Oh, wow. Two forms.
Yeah. So when it is floating outside a host cell just trying to infect you, it's in a form called an elementary body.
Okay, an elementary body.
Think of the elementary body as a tiny, heavily armored spore. It is metabolically inactive.
So it's not like eating or anything.
Right. It isn't feeding. It isn't replicating. It's just surviving. Just waiting to bump into a susceptible human cell, specifically the epithelial cells that line the reproductive tract.
So this armored little spore bumps into a human cell. What happens then? Does it just break the door down?
No, it actually tricks the cell into opening the door.
Wait, really?
Yeah, the elementary body attaches to the surface of the host cell, and the host cell, thinking it's just bringing in some normal nutrient or molecule, essentially swallows the bacteria.
Oh, that is so sneaky.
It engulfs it in a little pouch, and once it is safely inside the host cell, the bacterium completely changes shape. It sheds its armor and turns into its second form, which is called a reticulate body.
And I'm guessing this is where the trouble starts.
You guessed it. The reticulate body is the active replicating machine.
Okay.
It creates a protective bubble around itself inside the host cell, which clinicians call an inclusion. Safe inside this bubble, it starts stealing nutrients from the host and multiplying wildly.
Just hoarding resources.
Right. But here is the absolute genius of Chlamydia trachomatis. It doesn't immediately kill the host cell.
Oh, interesting.
In fact, it actively releases proteins that block the host cell from committing apoptosis.
Apoptosis, that's the cell's natural self-destruct mechanism, right? Like when it realizes it's been infected.
Precisely. It's programmed cell death.
So the host cell is trying to pull the fire alarm, and the bacteria is just standing there holding the alarm switch down, telling the immune system, everything is fine in here, nothing to see.
That is exactly what is happening. It downregulates the inflammatory signaling, Usually, when bacteria invade, your immune system recognizes the damage and floods the area with white blood cells.
Right, which causes the swelling and the pain.
Exactly. That rush of fluid and cells is what causes inflammation, redness, and pain. It's why a strep throat hurts so much when you swallow.
Yeah, that makes sense.
But because chlamydia keeps the host cell alive while it quietly replicates inside its little bubble, the immune system remains largely unaware.
It's basically invisible.
Completely. Eventually, the reticulate bodies transform back into those armored elementary bodies, the host cell ruptures, and the new bacteria spill out to infect the neighboring cells. And the cycle just repeats, incredibly quietly.
Well, that perfectly explains the concept the sources keep mentioning, right? The asymptomatic fraction.
Yes, the asymptomatic fraction.
This idea that the vast majority of infected women and a very significant portion of infected men experience absolutely zero symptoms. There's no massive, painful alarm bell that sends you rushing to the doctor.
And that creates a very unique public health nightmare.
How so?
Well, a disease that causes severe pain naturally limits its own spread. The host feels terrible, they stop having sexual contact, and they seek treatment, which breaks the transmission chain.
Right, because you feel sick, so you stay home.
Exactly. But chlamydia is free to spread in the dark. People can carry it for months, sometimes even years, passing it back and forth, entirely unaware that they are infected.
But, and this is crucial, the absence of pain does not mean an absence of damage.
Not at all.
And here is where the story really zeroes in on the devastating, specific physical toll on young women. Because if you look at the anatomy, the burden of this silent infection is not shared equally at all, is it?
No, it's not even close. In men, chlamydia usually infects the urethra.
Okay.
It can certainly cause complications like epididymitis, which is an inflammation of the coiled tube at the back of the testicle.
Right.
It can be uncomfortable, sure, but it rarely leads to profound, permanent, life-altering structural damage. For women, however, the anatomical layout creates this truly devastating cascade effect.
So if a woman contracts this and she feels perfectly fine, where does the bacteria actually set up camp and where does it go?
The initial infection typically establishes itself right at the cervix, which is the lower, narrow end of the uterus that opens into the vagina.
Okay.
Because there are no symptoms, no medical intervention happens. Left alone, the bacteria slowly ascend. They move up through the cervical canal into the cavity of the uterus, and then, crucially, they migrate outward into the fallopian tubes.
And we really need to pause and visualize the fallopian tubes for a second, because they are not like heavy-duty plumbing pipes. They are incredibly delicate, narrow structures.
They are exquisitely fragile. The internal passageway of a fallopian tube is incredibly narrow.
Like microscopic almost.
Very small. And it is lined with a highly specialized ciliated epithelium. Basically, millions of microscopic hair-like structures called cilia.
Okay, so these little hairs line the tubes.
Right. And these cilia beat in a synchronized wave-like motion. Their entire job is to gently sweep a fertilized egg from the ovary down through the tube and safely into the uterus for implantation.
So what happens when this silent replicating bacteria finally reaches these delicate tubes?
That is when the immune system finally wakes up to the invasion.
So finally.
Yeah, but it's too late. The bacteria have reached an environment where they cause a prolonged, low-grade immune war. The body sends in a specific type of white blood cell called neutrophils to attack the bacteria.
Okay, so the cavalry arrives.
They arrive, but neutrophils are very messy fighters. They release reactive oxygen species and enzymes meant to destroy the bacteria, but this friendly fire also destroys the delicate host tissue.
Oh no, so they're destroying the tubes while trying to save them.
Exactly. It obliterates those microscopic cilia. This massive inflammatory response in the upper reproductive tract is what clinicians call pelvic inflammatory disease, or PID.
And the really terrifying part isn't just the inflammation, right? It's how the body attempts to repair that battleground.
That's the real tragedy. The human body repairs severe tissue damage by sending in cells called fibroblasts, which lay down collagen.
So, scar tissue.
In other words, yes, it creates scar tissue. But while scar tissue is great for closing a cut on your arm, it is absolutely disastrous inside a microscopic, delicate tube.
I can imagine.
Even a tiny web of scar tissue can cause irreversible blockages or distortions in the fallopian tube.
You know, this makes me think of an analogy. We often talk about disease like a sudden hurricane. Like you see it coming, it hits hard, and it leaves obvious wreckage. But this biological mechanism is way more like an underground coal seam fire.
Oh, that's a good comparison.
Right. It sparks deep beneath the surface, burning incredibly slowly, completely out of sight. You walk over the ground every day and everything feels solid.
Yeah.
But underneath, the geological structure is quietly being turned to ash. Irreversible structural damage is being done in the dark, year after year, until one day you step on the wrong spot and the earth just caves in.
That captures the insidious nature of it perfectly. And that cave-in, for millions of women, happens years after the initial infection, usually when they decide they want to start a family.
Yeah, that's heartbreaking.
It really is. If the fallopian tubes are completely blocked by that scar tissue, the egg released by the ovary simply cannot meet the sperm. The result is permanent, long-term infertility.
Wow.
A silent infection at 19 quietly dictates a woman's reproductive future at 30.
And it actually gets even more dangerous if the tube isn't completely blocked.
Right.
Like, what if it's just partially damaged?
That introduces the risk of an ectopic pregnancy, which is a true life-threatening medical emergency.
Let's unpack the mechanics of that.
Sure. Think about the scale of the cells involved. A human sperm is incredibly tiny, about 0.05 millimeters long.
Okay, very small.
But an unfertilized egg is much larger, roughly 0.1 millimeters. So if the fallopian tube is partially blocked by scar tissue, the tiny, highly mobile sperm might still be able to swim past the obstruction and fertilize the egg.
But then the fertilized egg, which is now growing and dividing, has to make the journey back down.
And it gets stuck.
Oh.
The scar tissue acts like a net, trapping the growing embryo inside the fallopian tube, and the embryo has no idea it's in the wrong place.
It just does what it's programmed to do.
Exactly. Its outer cells, called trophoblasts, are biologically programmed to aggressively dig into the surrounding tissue to establish a blood supply. So they just dig right into the thin, delicate wall of the fallopian tube.
And the fallopian tube cannot stretch and expand like the muscular walls of the uterus can.
It absolutely cannot. As the embryo grows and digs into the blood vessels of the tube, the pressure builds until the fallopian tube literally ruptures.
Which means internal bleeding.
Massive internal hemorrhaging into the abdominal cavity. Without immediate emergency surgery to stop the bleeding, a woman can bleed to death very, very quickly.
That is terrifying.
It is. Ectopic pregnancy remains a leading cause of maternal mortality in the first trimester, and all of this lethal mechanics stems from a quiet, unnoticed infection years prior.
We also have to touch on the danger to newborns, because the sources are very clear that this cascade of damage doesn't stop with the mother.
No, it can pass to the next generation, sadly. If a woman has an active, asymptomatic chlamydia infection in her cervix at the time she goes into labor, the baby is exposed as it passes through the birth canal.
So the baby gets infected during birth.
Right. The bacteria can infect the newborn's eyes, leading to a severe conjunctivitis, or the baby can actually aspirate the fluids, drawing the bacteria into their lungs.
Which causes pneumonia, right?
Yes, a very distinct form of chlamydial pneumonia.
So to truly drive home the destructive power of this specific organism, the sources provide an incredible historical contrast.
They do, and it's fascinating.
We've been talking about the invisible damage it does domestically, but globally, this exact same biological entity has a completely different, highly visible legacy.
Yes, this is a really striking epidemiological contrast. If you study global infectious diseases, you will encounter a disease called trachoma.
Trachoma.
Now, trachoma is caused by Chlamydia trachomatis. It's just a slightly different variant, or serovar, of the exact same bacteria.
Okay, so same bug, different flavor.
Exactly. But instead of infecting the reproductive tract, these variants infect the conjunctiva, which is the delicate membrane lining the inner surface of your eyelids.
And the result of that infection is just horrifying. The sources note that trachoma is historically one of the world's leading infectious causes of blindness.
It is, and the cellular mechanism is literally identical to what happens in the fallopian tubes.
Wait, really? The exact same process?
The exact same. The bacteria infects the epithelial cells of the inner eyelid. It causes chronic, low-grade inflammation. Over years of repeated infections, the immune system responds by laying down scar tissue.
But in the eye, that scar tissue causes a mechanical nightmare.
It does. As the scar tissue on the inside of the eyelid matures, it contracts and tightens. This pulls the edge of the eyelid inward, a condition called entropium.
So the eyelid rolls backward.
Right. As the eyelid rolls inward, the eyelashes are dragged directly across the surface of the eye. This is called trichosis. Every single time the person blinks, their own eyelashes scrape and scratch the clear cornea.
Oh, it sounds like absolute torture.
It is excruciatingly painful, and over time, that constant physical scratching causes the cornea to turn cloudy and opaque, leading to irreversible blindness.
That is so tragic.
Now think about the public health response to this. Because the suffering of trachoma was right there on the face of the patient, because you could visibly see the scarred eyelids and the clouded eyes, it mobilized massive global health initiatives for decades.
Because it was a tragedy you could actually see.
Exact.
But the exact same biological weapon, I mean, the scar tissue resulting from chronic chlamydial infection, when deployed in the dark of the reproductive tract, was essentially ignored for a huge chunk of medical history.
Out of sight, out of mind.
The blindness of trachoma was a global visual tragedy, but the reproductive scarring was a domestic, invisible one.
And that invisible tragedy brings us to a really profound historical dilemma. Because the ultimate irony of everything we have just discussed, the infertility, the ectopic pregnancies, the pelvic inflammatory disease, is that for the last several decades, the medical field has actually possessed a perfect, inexpensive weapon to stop it.
Which introduces what I think of as the paradox of the cure.
Yes.
If we transition into the historical timeline, we enter a long period where the medicine worked perfectly, but the system failed completely.
To understand the historical diagnostic blind spot, you really have to realize a crucial distinction between chlamydia and other sexually transmitted infections, like gonorrhea.
Okay, what's the difference?
When you look at the clinical guidelines for chlamydia, the treatment is shockingly simple. It is easily cured.
We aren't talking about complex intravenous therapies or months of treatments here.
Not at all. A highly effective, short, and incredibly inexpensive course of oral antibiotics clears the infection reliably.
Like what kind of antibiotics?
We use drugs like azithromycin, which is often given as a single dose, or doxycycline taken for 7 days. These antibiotics work by binding to the bacterial ribosomes, effectively shutting down their ability to synthesize proteins.
Oh, nice.
Without new proteins, the reticulate bodies inside the cell cannot replicate and the infection just dies out.
And unlike gonorrhea, which seems to make headlines every few years for turning into a superbug, chlamydia hasn't built up massive drug resistance.
It's a fascinating biological quirk, actually. Gonorrhea is notorious for acquiring genetic mutations and plasmids from other bacteria, building this huge wall of resistance against almost every class of antibiotic we've ever deployed against it.
But chlamydia doesn't do that.
No. Because chlamydia is locked away inside its little inclusion bubble within the host cell, it is largely isolated from the vast genetic swap meet of other bacteria in the body.
It doesn't get to mingle.
Right. It doesn't have the same opportunities to pick up resistance genes. So the antibiotics work just as brilliantly today as they did decades ago.
Okay, if I am a listener right now, my head is totally spinning.
Let's lay this out logically.
Yeah, let's unpack this. We have an infection that causes 1.65 million reported cases a year. It ruins the reproductive futures of young women.
Right.
But we also have a cure that costs pennies, works almost every single time, and has no significant drug resistance. Why on earth hasn't this been eradicated? If the cure is so simple, why is it the most common reportable infection in America?
It is the single most important question to ask. And the answer is that for most of the 20th century, the cure was never the problem.
The antibiotics were sitting right there on the pharmacy shelf.
Exactly. The problem was finding the disease. For decades, medicine suffered through a diagnostic dark age because our tools for seeing into the microscopic dark were incredibly, almost laughably primitive.
It's one thing to say the disease was hard to find because it was asymptomatic. But even if a doctor suspected it, the actual process of diagnosing it back in, say, the 1970s sounds like an absolute nightmare.
It was an arduous, highly technical, and frankly brutal process. Remember, because Chlamydia trachomatis only lives inside human cells, you couldn't just take a quick, painless swab of fluid, smear it on a glass slide, and look for swimming bacteria under a standard clinic microscope.
It works for gonorrhea, right?
It does. It does not work for chlamydia.
So what did a doctor actually have to do to prove a patient had chlamydia in 1975?
They had to perform a procedure known as a cell culture. And specifically, they used something called the McCoy cell culture technique.
The McCoy cell culture. Sounds complicated.
It was. First, the clinician had to perform a full, invasive pelvic exam. They had to take a harsh swab and vigorously scrape the cervix.
Scrape the tissue itself. Ouch.
Yes, because they needed to harvest actual human epithelial cells that might contain the hidden intracellular bacteria. This was deeply uncomfortable for the patient.
I could only imagine.
Then, the nightmare of logistics began. That swab had to be placed in a very specific transport medium, usually a sucrose phosphate buffer, and it had to be kept strictly refrigerated.
The cold chain. We hear a lot about that with vaccines.
The cold chain was vital here, too. If the sample got too warm in the back of a delivery car, the fragile bacteria inside the human cells would die before they even reached the lab.
So the test would be ruined.
Exactly. And once it finally arrived at a highly specialized elite laboratory, the technicians essentially had to run a massive science experiment.
How so? What were they doing in the lab?
Well, they had petri dishes or vials lined with a monolayer of living animal cells, usually McCoy cells, which are a type of mouse fibroblast.
Okay, mouse cells.
They would take the patient's swab and introduce it into the vial. Then they had to put the vial into a centrifuge and spin it at high speeds.
Wait, they had to centrifuge it. Why?
To physically force the chlamydia elementary bodies from the patient's sample to crash into and attach to the mouse cells in the vial.
Oh, wow. They had to forcefully smash them together.
Right. Then they would put the vial in an incubator for 48 to 72 hours, hoping the bacteria would successfully infect the mice cells, transform into reticulate bodies, and form those protective inclusion bubbles.
So 3 whole days later, they pulled the vial out. Do they just see it then?
No, they had to chemically fix the cells, stain them with iodine or highly specialized fluorescent antibodies, and then a highly trained technician had to sit at a microscope and meticulously scan the cellular landscape, hunting for the glowing green inclusions inside the cells.
That is absurd. The amount of labor, the cost, the margin for error.
The margin for error was massive. If the transport was too warm, if the centrifuge was too slow, if the technician blinked, the test came back negative.
So the test was incredibly expensive, incredibly slow, and wildly impractical for routine screening.
Exactly. You couldn't just run that protocol on a million completely asymptomatic 19-year-olds who just came in for a regular checkup.
So what happened? Who actually got tested?
The testing was heavily rationed. It was reserved primarily for women who were already in the emergency room showing severe symptoms of pelvic inflammatory disease.
Which means we were entirely reactive.
Entirely. We only deployed the diagnostic test and therefore the antibiotic cure after the house had already burned down.
We were treating the aftermath of the scarring.
Right. We were completely missing the window for actual prevention.
It's just an agonizing reality.
Mm-hmm.
To have the perfect fire extinguisher right in your hands, but to be totally blind to the sparks. You could only use it once the roof caves in.
It was incredibly frustrating for doctors.
And this agonizing gap between the cure and the diagnosis created a desperate need in the public health community for a technological miracle. And in the 1990s, that miracle finally arrived.
It did. The entire landscape of public health was transformed by the NAT revolution.
NAAT nucleic acid amplification tests. This is where the story pivots from medieval scraping to modern molecular magic.
Molecular magic is a great way to describe it.
When you read the history of this, it isn't just an upgrade in lab equipment. This was a complete paradigm shift that changed what it meant to be a doctor.
Yeah.
But to understand why it was a miracle, we have to understand what a NAT actually does.
Right. To understand NATs, you have to understand the core technology behind most of them, which is PCR, or polymerase chain reaction.
So instead of the agonizing McCoy cell culture, where you are trying to find a needle in a haystack by pulling the haystack apart piece by piece, how does PCR work? Let me try an analogy here.
Let's hear it.
Let's say you are looking for a specific torn half sentence from a specific book hidden somewhere in a massive dark library. The old way was visually inspecting every single book. PCR is like pouring a chemical spell into the library that ignores every other book, finds that one torn half sentence, and magically commands it to print 1 billion copies of itself until it literally floods the entire room.
That is an exceptionally accurate analogy for molecular amplification. With PCR, the lab doesn't need live bacteria inside human cells. They don't need a cold chain. They just need a microscopic fragment of the bacteria's DNA or RNA.
How does the lab actually force it to print 1 billion copies? What is the actual mechanism?
It relies on a machine called a thermal cycler. They take the patient's sample, which might only have a few dead fragments of chlamydia DNA, and they heat it to nearly boiling, about 95 degrees Celsius.
Okay, very hot.
Now, DNA is a double helix, right? 2 strands zip together. The heat melts the bonds, unzipping the DNA into 2 single strands.
Okay, so the DNA is unzipped, like a literal zipper.
Then they cool it down slightly to around 55 degrees, and they add primers into the mix. Primers are tiny synthetic sequences of DNA designed in a lab to act like homing beacons.
Oh, I see.
They are coded to attach only to the specific genetic sequence of Chlamydia trachomatis. They ignore all the human DNA and all the other normal bacterial DNA in the sample.
They just lock right onto the target.
Exactly. Once the primers lock on, the machine heats the sample back up to 72 degrees. And this is where the magic happens.
What happens at 72 degrees?
They use a special enzyme called Taq polymerase. Fun fact, this was originally discovered in bacteria living in the boiling hot springs of Yellowstone National Park, so it can actually survive extreme heat.
Oh, wow. Yellowstone. That's wild.
Yeah. This Taq polymerase grabs onto the primer and rapidly builds a perfect complementary strand of DNA, zipping it back into a double helix.
So you started with one fragment of DNA, unzipped it, and now you have two identical double helixes.
Yes. And then the machine just repeats the cycle. Heat, cool, build. Heat, cool, build. It takes just a few minutes per cycle.
So it happens fast.
Very fast. After 30 cycles, you don't have two copies. Because it grows exponentially, 2, 4, 8, 16, you have over 1 billion copies of the chlamydia DNA.
It just amplifies the signal until it is overwhelmingly obvious.
Precisely. And because you only need a microscopic fragment of DNA to start the process, it completely revolutionized the collection method. You no longer needed to aggressively scrape the cervix to harvest whole human cells.
Which means no invasive pelvic exams just for testing.
Right. The bacteria naturally shed enough DNA into the urogenital tract that you could detect it in a simple, non-invasive urine sample.
You literally just pee in a cup.
You pee in a cup. Or a patient can use a simple, painless, self-collected vaginal swab. And from that instant, non-invasive sample, the lab can tell you with near-perfect accuracy if the silent infection is present.
The sources include these incredible insights from clinicians who lived through this transition.
Yes, the relief is palpable in their accounts.
If you were a gynecologist in the 1980s, your clinical life was full of heartbreak. You were the one sitting in the room telling a 28-year-old woman that her tubes were blocked, that she was permanently infertile.
And you knew that if you had just been able to catch a silent infection 5 years earlier, a $5 pill would have saved her.
But your hands were totally tied by the technology.
The frustration must have been suffocating, to constantly treat the irreversible aftermath, knowing the cure existed but the radar didn't.
But then the late 90s roll around, and the gnat arrives in the clinic. And the relief these doctors describe is profound.
It changed everything.
Because suddenly, you hand a healthy-feeling 19-year-old a plastic cup, she brings it back, you run the test, and 2 days later you call her up and prescribe an antibiotic. You just saved her reproductive future, and she didn't even know she was in danger.
Gnats fundamentally altered the timeline of medical intervention for this disease. They turned chlamydia from a reactive disease to a proactive one.
We stopped waiting for the fire.
Exactly. In the cell culture days, medicine waited for the damage. With gnats, medicine found the pathogen in advance. And because a urine cup doesn't require a specialized gynecological setup, it democratized the diagnosis.
You can do it anywhere.
You could run these tests at a primary care physical, at a community health clinic, even at a high school-based health center. Mass screening finally became physically and economically practical.
But having a miraculous test in a lab is totally useless unless there is a nationwide strategy to actually deploy it. I mean, having the compass doesn't help if the government refuses to build the ships.
That's a great point.
This technological leap directly enabled the federal government to construct a totally new kind of public health strategy.
Which brings us to the architecture of the modern public health response. The quiet machine.
I love how the sources frame this because they contrast it with the older models of public health we are all familiar with. In the past, public health was loud.
Yes, the classic example is what historians call the Perron mold, named after Thomas Perron. He was the incredibly aggressive Surgeon General of the United States in the 1930s and 40s.
Okay.
His enemy was syphilis, and his approach was a massive, highly visible war effort.
Like loud posters in every post office, radio broadcasts, mandatory blood tests for marriage licensing.
Exactly. He utilized government-funded rapid treatment centers where patients were given massive regimens of penicillin. It was public, it was moralistic, and it was loud.
Right.
But you can only wage a loud campaign against a disease that people know they have or one that has visible, horrifying late-stage symptoms like syphilis.
You can't wage a loud war against an enemy that feels like nothing.
Right. So for chlamydia, the federal government had to invent something else entirely. They utilize the innate technology to build a quiet machine, a structural apparatus built entirely around one function, which is finding.
So what does that machine actually look like on paper? Where does the power come from?
The architecture is built on formal clinical guidelines, specifically the guidelines issued by the Centers for Disease Control and Prevention, the CDC, and an even more structurally powerful body called the U.S. Preventive Services Task Force, or USPSTF.
What exactly is the USPSTF? They sound like a bureaucratic shadow government for medicine.
They kind of are, but in a good way. They are arguably one of the most influential bodies in American healthcare. Formed in 1984, they are an independent volunteer panel of national experts in prevention and evidence-based medicine.
Okay.
They exhaustively review the scientific literature on screening tests and preventative medications. When they issue a grade A or grade B recommendation for a screening test, it becomes the absolute gold standard for clinical care.
And it has actual financial teeth, right?
Massive financial teeth. Under modern healthcare laws like the Affordable Care Act, private insurance companies are legally mandated to cover preventive services that receive an A or B rating from the task force without charging the patient a copay or deductible.
Okay, so when this task force speaks, the entire medical system moves. What is their exact standing order regarding chlamydia?
The CDC and the task force have a crystal clear recommendation. Every sexually active woman aged 24 and younger must be screened for chlamydia annually.
Every single year.
Every single year. They also recommend screening for older women who have increased risk factors, like new or multiple partners.
So every time a young woman under 24 comes into a clinic for a birth control refill, a sports physical, or a pap smear, the system is structurally programmed to hand her a plastic cup and run the NADMO.
That is the machine operating in the background.
But wait, we have to pause and critically examine this policy for a minute. If chlamydia is the most common infection in the United States, if it infects men and women, why is the federal guidance hyper-focused on women age 24 and younger?
It's a very fair question.
Like, why an age cutoff of 24? And more glaringly, what about the men? Why aren't we handing the cup to every 20-year-old guy who walks into a clinic?
This is where we have to dive into the cold, calculated economics of public health policy. Public health isn't just about what is theoretically possible. It is about allocating finite resources to achieve the maximum reduction in severe human harm.
The concept of QLALY, right? Quality adjusted life years.
Exactly. When the task force evaluates a screening program, they look at how many resources it takes to save one quality-adjusted life year. The severe, life-altering harm of chlamydia, the permanent infertility, lethal ectopic pregnancies, chronic pelvic pain happens almost exclusively to women.
Right.
Therefore, catching a silent infection in a young woman results in a massive QALY save. It prevents catastrophic downstream pathology.
Okay, so the benefit to women is huge, I get that. But why specifically women 24 and younger? Do older women magically become immune?
No, but they become biologically far less susceptible. It comes down to cellular anatomy, actually. Young women, particularly in their teens and early 20s, frequently have a condition called cervical ectopi.
What does that mean?
It means that the delicate, single-layer columnar cells that normally line the inside of the cervical canal are pushed outward, extending onto the outer vaginal face of the cervix.
Oh, I see.
These single-layer cells are incredibly vulnerable to Chlamydia trachomatis. As a woman ages into her late 20s and 30s, those cells undergo a process called squamous metaplasia.
They change.
They transform into tougher, multi-layered squamous cells, which act like a thicker layer of armor, making it physically harder for the bacteria to establish an infection.
Wow, so young women are both biologically the most vulnerable to catching it and structurally the most likely to suffer catastrophic damage from it. That explains the target on their backs.
It does.
But let's get back to the men for a second. Even if men don't suffer this severe structural damage, they are carrying the bacteria. They are transmitting it. If you only screen the women, aren't you just bailing water out of a sinking boat without actually plugging the hole?
You are. Epidemiologically, it is a glaring vulnerability. By not having a universal mandate to screen asymptomatic young men, the system accepts the existence of a massive, untested reservoir of asymptomatic spreaders.
A male reservoir.
Yes. A young man can carry the infection for a year, feel completely fine, never be prompted for a test at his brief medical checkups, and unknowingly transmit the bacteria to multiple female partners.
And the medical community just accepts this.
The medical community recognizes this. But when the task force runs the math, massive national screening programs for men are incredibly expensive. And because men don't develop PID or ectopic pregnancies, the direct medical cost savings just don't align in the models the same way they do for women.
It is a profound compromise. The machine is brilliantly designed to protect the immediate victims of the structural damage, but it has a built-in blind spot regarding the source of the ongoing transmission.
Exactly.
But even with that blind spot, issuing a standing order to test every young woman is a massive undertaking. And as we know, an order written on a piece of paper in Washington, D.C. doesn't magically pay for lab tests in rural Ohio.
Which brings us to the ultimate vulnerability of this entire architecture.
The vulnerability of the machine. Budgets, clinics, and rising tides. Because a system built entirely on screening is a deeply fragile thing.
The federal government understood that you cannot mandate a test without building the infrastructure to deliver it. So, alongside the recommendations, they created federally supported infertility prevention screening programs.
Okay, so they did put money behind it.
They did. They funneled money through mechanisms like Title X family planning grants and CDC block grants.
Where did that money actually go? On the ground?
It went directly to the front lines, to public health clinics, community health centers, and family planning clinics across the entire country.
Nice.
The explicit goal was to buy the not testing kits and pay the lab technicians so that uninsured and lower-income women who couldn't rely on private insurance mandates could still receive their annual screening for free or at a drastically reduced cost.
They were funding the radar station.
Exactly. For a time, this massive injection of federal funding rapidly expanded testing networks. But here is the critical, inescapable flaw of a passive screening strategy.
What's the flaw?
It requires the patient to walk through the clinic doors, and it requires the clinic to be open and fully funded.
It is entirely dependent on the physical infrastructure of local healthcare.
And when you examine the epidemiological data over the last decade, the fragility of that infrastructure is blatantly obvious. Despite the standing orders and the grant programs, screening rates among eligible young women remain vastly incomplete.
We've never hit the target.
We have never come close to 100% compliance with that annual screening rule.
And as a result, the reported case counts just relentlessly keep climbing, year over year, setting new records right up to that 1.65 million mark in 2023.
Now, I must introduce a very important nuance from the epidemiological sources regarding those rising numbers.
Oh, definitely.
When a public health official looks at a graph showing a massive, steep climb in chlamydia cases starting in the late 1990s, they have to separate two phenomena. Is this a rising disease, or is this just rising detection?
Oh, that totally makes sense. Because if you invent a miraculous molecular copy machine, the NADAT, and you start pushing thousands of clinics to test millions of asymptomatic women, of course your numbers are going to explode. You're finally turning the lights on in a room that was always full of bugs.
Exactly. A huge portion of the historical surge in reported cases was a direct successful result of better technology and the rollout of the screening programs.
So finding more of it wasn't a failure. It meant the invisible machine was working.
Precisely.
However,
There is always a however in public health. Always. However, the sources acknowledge that we have moved past the era of simply turning the lights on. The persistent, relentless upward trend we see today, especially in recent years, cannot be entirely explained by better testing.
it's actually spreading more.
It clearly points to incomplete screening and unabated active spread. The disease is actively outrunning the machine.
And why is it outrunning it? Because we keep unplugging the machine. We have to impartially analyze the direct impact of budget cuts here. Because the entire federal strategy runs through local clinics and public funding, it is acutely, terrifyingly vulnerable to political disinvestment.
It is the Achilles heel of modern structural public health. If your strategy is a loud 30-day vaccination drive, you fund it once, you execute it, and it's done.
Right.
But if your strategy is a quiet machine of daily routine screening, you are eternally dependent on the daily operating budget of thousands of local clinics.
Let's break down the mechanics of a budget cut. What actually happens on the ground? Let's say a state legislature or the federal government decides to slash Title X funding or cut the public health budget by 20%.
The impact is immediate, even if no one notices it on day one. When funding is cut, a public clinic cannot run a deficit. They have to react.
What does it do?
They reduce their operating hours, they close on Fridays, they lay off the community outreach workers who remind young women to come in, or, in severe cases, the clinic simply closes its doors permanently.
And when the clinic closes, The screening stops.
The screening stops immediately. The gnats are not run. But because the disease is entirely silent, the patient doesn't know she is sick. The doctor isn't there to hand her the cup, and the infection simply slips right back underground.
It vanishes from the data.
It vanishes from the Excel spreadsheets at the CDC, but it continues to replicate. It continues to ascend from the cervix into the uterus. It continues to trigger the neutrophils. It continues to lay down scar tissue in the fallopian tubes. The disease doesn't retreat, our vision of it does.
Going back to our analogy, it's like spending a decade developing a state-of-the-art early warning radar system to protect a coastal city. You build the towers, you perfect the molecular software, the radar is spinning, and you can see every single threat on the screen.
Right.
But then, to balance a ledger, the city decides to cut the budget by refusing to pay the electric bill for the radar station. The screens go dark. The threat didn't magically go away. The storm is still coming. We just willfully closed our eyes.
That is precisely the dynamic. And the ultimate tragedy is that the consequences of that willful blindness are not borne by the policymakers who cut the budgets. They are borne by the individuals.
Let's bring this all the way back to the listener. Let's step away from the millions of cases, the federal acronyms, and the cellular biology, and focus on the deeply personal human cost for the women who lack consistent access to these screening programs. Because a failure of infrastructure translates directly into individual devastation.
Imagine the timeline of a young woman who relies on a publicly funded community health clinic. She is 19. She goes there for her birth control. And because the clinic follows the USPSTF guidelines, they screen her for chlamydia every single year.
The machine's working perfectly for her.
It is. But then a wave of budget cuts hits her state. The clinic loses its grant funding and shuts down. For the next 3 or 4 years, she doesn't have an easy, affordable, accessible place to get routine preventive care.
She's just out there without a safety net.
She buys condoms at the pharmacy, but she isn't getting tested. Sometime during those dark years, she contracts Chlamydia trachomatis.
And she has absolutely no symptoms, no fever, no pain.
0 symptoms. The reticulate bodies replicate, the infection ascends into her fallopian tubes, the low-grade immune war begins, the cilia are destroyed, and the microscopic scar tissue is laid down.
It's all happening in the dark.
5 or 6 years pass. She is now in her late 20s. She is married, she is financially stable, and she is ready to start a family.
But months go by, and she can't get pregnant.
She tries for a year. Finally, she goes to a fertility specialist. The specialist performs a procedure called a hysterosalpingography. They inject a special dye into her uterus and take an X-ray to see if the dye flows freely out through her fallopian tubes.
And the doctor looks at the X-ray.
The doctor points to the monitor and tells her that the dye is completely blocked. Her fallopian tubes are filled with dense scar tissue.
And in that tiny, sterile room, the realization just hits her.
She realizes that her natural fertility is gone, that if she wants a child, she will have to undergo incredibly expensive, physically grueling in vitro fertilization procedures.
It's devastating.
And the most heartbreaking part is knowing that all of this permanent, life-altering grief is the result of an infection that a simple, painless urine test could have caught and a $5 course of generic antibiotics could have cured in a week.
That is the real cost of unplugging the radar. It is a failure of the invisible infrastructure.
It is, and it happens every single day.
Which really brings us to the end of our journey today. Let's recap the narrative arc we've traveled. We started by looking at a biological master of self, an organism that evolved to hide inside our cells, actively suppressing our immune alarms. A disease defined by silence, one that quietly burns through the reproductive structures of young women.
We saw how that silence made the disease nearly impossible to fight during the diagnostic dark ages, leaving doctors with nothing but medieval scraping techniques and reactive treatments for permanent damage.
Until the gnats arrived.
Right, until the brilliant invention of molecular amplification, the gnat, finally gave us the ability to find a needle in a genetic haystack.
We saw how the federal government took that technological miracle and built a massive, quiet machine of public health around it. Not a loud war with posters, but a standing order embedded in the clinical code of the nation, demanding we screen every young woman every year.
A truly structural intervention.
And finally, we saw the fatal flaw in that beautiful machine. It only works if we pay to keep the doors open. When we allow incomplete screening and fragile clinic funding to persist, we allow a completely curable disease to relentlessly spread.
Analyzing this history really forces us to look at public health through a completely different, highly structural lens.
I want to leave you, the listener, with a final thought to mull over. building on everything we've unpacked today. Chlamydia is the purest example of public health power operating invisibly. It isn't a dramatic quarantine. It isn't a mandatory vaccine requirement. It's just a recommendation, a cheap test, and a background program running in local clinics.
And that raises a provocative, enduring question for all of us. If the only thing standing between millions of people and permanent, life-altering harm is a quiet, bureaucratic machine running in the background, what happens to our society's health when we stop paying attention to and start paying for the infrastructure we cannot see?
1.65 million cases. A silent epidemic fighting an invisible machine. The real threats, the ones that touch millions of lives and alter futures, they don't announce themselves as sirens. They hide in the microscopic dark. And the only way to fight what you cannot see is to build systems that never stop looking. Thank you so much for joining us on this deep dive. Keep asking questions, keep demanding to understand the mechanics of the world around you, and always look beneath the surface of the systems built to protect you.